President Esther Garcia, Dr. Alma Lucindo Jimenez, Dr. Emiliano Aligui, Deans of the colleges and their faculty, staff, officers of the hospital, chairs of the various departments, family members and friends of Dr. Jaime Saguire, distinguished guests, students, ladies and gentlemen. A pleasant morning to all of you. Today, we honor the memory of Dr. Jaime C. Saguire and his legacy, the concept of the individual human being composed of the soma, psyche, and spirit. Underpinning the complex relationship of the soma, mind, and spirit is the uniqueness by which each person reacts to a given stimulus. Once again, the discussion of our distinguished speaker this morning, Dr. Alma Lucindo Jimenez, will booster these concepts. Dr. Saguire had long ago preached the solid relationship between the soma and the psyche. I am very fortunate to have seen and listened to Dr. Saguire as he taught the concept that remains the fundamental guiding principle for many psychiatrists in daily practice. We are grateful to Dr. Alma Lucindo Jimenez for accepting our invitation to give the 31st Dr. Jaime C. Saguire Memorial Lecture on the therapeutic relationship in online psychotherapy. We would also like to thank the Department of Psychiatry and the Committee on Special Conferences for making this memorial lecture possible. We look forward to a fascinating discussion this morning. Thank you very much.
Thank you, Dr. Uy. May I now call on Dr. Elhame Zibo-Calbos, Head of the Department of Psychiatry, for her opening remarks.
President Dr. Esther A. Garcia, Vice President of the Board and the Chief Operating Officer, Mr. Wilson T. Young. I think he might be online. And the Vice President for Academic Affairs, Dr. Emiliano Aligui. Dean Dr. Norbert Lingling Uy, the Vice President for Hospital Services and Chief Medical Officer, Dr. Maribeth T. de los Santos, and the officers of the hospital officers, chairpersons of the different departments, and our immediate past chairman, Dr. Nori Balderrama, the Committee on Special Conferences headed by Dr. Debbie P. Songco, our past memorial lecturers who are here with us today, the family of Dr. Saguire, represented by Mrs. Bituin Saguire Almonte, and please indulge me in acknowledging the presence of the officers of the Philippine Psychiatric Association Board of Directors and members headed by Dr. Robert D. Benaventura. Some of them are online. We're actually having more than 220 audience online. And some the members and officers of the Philippine Society for Child and Adolescent Psychiatrists, the officers and members headed by Dr. Vanessa Cainhug, and members and officers of the Philippine College of Psychopharmacology, also headed by Dr. Melissa Mariano. Our online audience, our distinguished guests, dear colleagues, students, ladies and gentlemen, good day. It gives me a great pleasure to give my opening remarks to this hybrid event. On its 31st Dr. Jaime C. Saguire Memorial Lecture. Therapeutic Relationship, which is an interactive relationship with a patient, and family that is caring, clear with boundaries, positive and professional is what we all want to achieve from the onset of consultation, which is seen as a factor that enhances treatment, adherence, and faster recovery. This is not exclusive to psychiatrists. Rather, if other specialties or caregivers of patients build this type of relationship too. The late Dr. Jaime Zaguirre, the proponent of the individual human person, the soma, psyche, and spirit concept in dealing with illness and in treatment, sees this as a fundamental in healing by incorporating in therapy. Over this pandemic, how many of you are using online platform for consultation? Was there a change on how you built your relationships or you manage patients online? It's impeccable timing talking about this online therapeutic relationship after 3 years of online consultations. So as the platform or the online platform is here to stay, even when the pandemic is over. Just like many of you, I am also excited to listen and learn from our dear speaker and of course, the students also and our residents. Now we'll learn a lot from today's lecture. So ladies and gentlemen, as I open this event, I thank all of you who have supported this hybrid event. And to Dr. Alma Lucindo Jimenez, our heartfelt gratitude for being our 31st memorial lecturer. As Dr. Luspo would say it, the Zaguirre spirit lives on. Thank you and good morning.
Thank you, Dr. Bocalbos. To honor Dr. Zaguirre's memory, may I call on Dr. April Fatima J. Hernandez, the current Residency Training Officer, for a tribute to the life and works of Dr. Jaime C. Zaguirre.
Good morning, everyone. The best way to pay tribute to someone like Dr. Jaime C. Zaguirre is not only through honoring him today in today's memorial lecture, but also through practicing his greatest contribution in psychiatry, the individual human person. IHP, as we call it, is the core concept in the soma, psyche, and spirit model in understanding disease process. Dr. Zaguirre's teachings implore not to limit to just understanding the illness and treatment with medicines, but to understand the person with the illness as well. The Department of Psychiatry developed instructional design both in the College of Medicine and in the hospital residency training guided by these principles. It is my pleasure to introduce the man ahead of his time, Dr. Jaime C. Zaguirre, through a video prepared by our dear consultant, Dr. Cherry Rich Cheng.
As we move on to the highlight of this event, may we call on a highly esteemed and regarded member of our faculty, Dr. Norieta C. Balderrama, to introduce our keynote speaker for today.
President Esther Garcia, our distinguished guest speaker for today, and our colleague, Dr. Alma Lucindo Jimenez, Vice President for Academic Affairs, Dr. Aligi, Dean of the College of Medicine, Dr. Norbert Lingling Uy, Deans of the other colleges, hospital admin officers, past Aguirre Memorial lecturers. I see Dr. Lesaca and of course, Dr. Rodriguez, the Aguirre family, chairs of the different departments, faculty, beloved students, guests, ladies and gentlemen, a pleasant good morning to everyone. Today, the task of introducing our guest of honor and speaker is a great privilege for me. As the 31st Dr. Jaime Aguirre lecturer, we have invited a well-renowned psychiatrist, not only in our country, but also internationally. She's been a living inspiration to our students and young psychiatrists and embodies the 5-star physician we all want to achieve. At present, Dr. Jimenez is a senior advisor, Psychotherapy Section, World Psychiatric Association, member of the International Advisory Editorial Board, Psychodynamic Psychiatry, American Academy of Psychoanalysis and Psychodynamic Psychiatry. She's also an associate editor Editorial Board, Tasman Psychiatry 5th edition. So we have this reference in our library. It is one of our references. A consultant, Editorial Board, Philippine Journal of Psychiatry, and a reviewer, Editorial Board, Acta Medica Journal, UP College of Medicine. She finished her Doctor of Medicine from the UP College of Medicine and her BS Pre-Med course cum laude from the University of the Philippines, Diliman, and was also chief resident at the UP-PGH Department of Psychiatry and Behavioral Medicine, where she was also a training officer. So I have 10 pages. She has also been an associate professor, UP-PGH College of Medicine, and the founder chairperson, Department of Psychiatry and Behavioral Medicine, San Beda College of Medicine. She has held numerous administrative positions, to name a few: the head of UP Manila Committee on Mental Health Program, Social Media Policy Commission, UP College of Medicine, to being the director of the Center for Gender and Women's Studies, UP Manila, and coordinator, Office of Anti-Sexual Harassment, UP Manila. She was also head of Consultation Liaison section of the Department of Psychiatry and Behavioral Medicine, UP-PGH, and she also worked with the Department of Health. That's so long ago. In her capacity as Executive Assistant, National Program on Mental Health, and Secretary Project Team on Mental Health. She's been a member of the editorial board of the National Formulary Committee, Philippine National Drug Policy Essential Drugs, Editor Handbook of Rational Drug Use in Psychiatry, DOH National Program for Mental Health. She has also received numerous recognitions, honors, and scholarships, first from being the PPA Outstanding Teacher in Psychiatry, to UP College of Medicine Best Teacher in Psychiatry, to UP Manila Centennial Professor of Psychiatry. She has held numerous positions in different societies, from being the chair of the World Association for Dynamic Psychiatry, Philippine Regional Branch, and also the President, Asia Pacific Association of Psychotherapists, and past president of the Philippine Psychiatric Association, where we are members. And it was, of course, during this time, her time as president, where I had the honor of working with her. So our guest speaker for today, an accomplished and somebody who made the difference in the lives of so many, including yours truly. So today, colleagues, our dear students, guests, please join me in welcoming our 31st Dr. Jaime Seguire Memorial Lecturer to talk about the therapeutic relationship in online psychotherapy. Kindly give a warm of applause to Dr. Alma M. Lucindo Jimenez. Thank you.
Thank you.
Ganito po ba? Ganyan. Panti pa. Okay na. Ito. Okay. Thank you for that kind introduction, Nori. Good morning, everyone. I would try to go through that long list of VIPs. I will still try. No, I only got some names from someone who said they're the ones who are present. So let me try this. Dr. Esther Garcia, Dr. Emiliano Aligi, Dr. Wilson Young, Dr. Norbert Lingling Oy, Maribeth de los Santos, Dr. Elham Bocalbos, and Miss Between Zagire. Good morning, everyone. Thank you for inviting me in this auspicious occasion to address you. I am honored to be able to speak to you as a tribute to Dr. Zagire. I have learned about his passion to look at the whole person, the soma and the psyche. And this is right down my alley. As I look out into the audience, I see the faces of past presidents, but they cannot see me, I think. Okay. There's Des Rodriguez, there's Nori, there is, of course, the present president, Bong Buenaventura. Zita is not here. Who else am I missing? Of course, there's Portia Luspo. And then the present leaders and the future leaders in Philippine psychiatry. Of course, I would like to make a shout out. The young people would say a shout out to Dr. Rooney Lasaka, who was one of my mentors in the National Program for Mental Health. And I am indeed honored that he has taken the time to be here. Of course, on a very personal note, my kumpare, Dr. Israeli Europa is here. I think he is the grandfather of my grandson. He's the grandfather of my grandsons. So he's the son, my balae. Yes. So I think he's here to check out the genes. So let's see from which side of the family our rambunctious grandsons take their spirit. Okay, so let me start. Calling out those people from the audience who are closely associated with Philippine psychiatry. I recognize the legacy of the man we pay tribute to today. Thus, I move to speak on a matter that presages the future of psychiatry: the therapeutic relationship in video therapy. The lines of a song by the British boy band One Direction keep running in my head. Pwede ko rin ikanta yan kung gusto nyo. Wag na. Does it ever drive you crazy just how fast the night changes? One day, we were doing therapy in our clinics. The next day, we conducted therapy from home through web-based platforms. What happened? COVID-19 happened. The worldwide lockdown happened. It killed us, made a lot of us sick, forced us to change the way we live, work, and play. It shined a light on how physical ill health and social disruption affect mental health. It also removed in-person, face-to-face therapy, our first line response to mental health challenges. In 2020, the World Health Organization determined that the psychological consequences of the pandemic is a public health issue and that it was critical for people in need of mental health treatment to continue having access to treatment in an infection-free setting. In the same year, the United Nations pushed for mental health services to be delivered online. The need for mental health services increased. Those infected with the virus, those who lived in fear of the virus, those dealing with the consequences of the virus, and the health workers, along with those with pre-existing mental health problems, those with high risk of mental health challenges, the old, those with chronic medical illnesses, compounded the burden of global distress and anxiety. Access to therapy, already limited by the worldwide mental health treatment gap, and the underutilized video therapy resources further decreased as the numbers needing mental health services increased. Global distress and anxiety outweighed the access to therapy, tipping the scale. And the WHO and the UN had put the responsibility of correcting this imbalance directly on the shoulders of mental health workers. Video therapy resources had been around since the 70s as an outreach measure for the underserved in remote areas and those unable to attend in-person psychotherapy. The need for it glared and the acceptance from patients were noted. The promised good outcome studies were delivered. By the 90s, it had a central role in treating mental health consequences of infectious disease outbreaks and had evidenced effective symptom reduction for depression, anxiety, and PTSD in different modalities. But mental health professionals carped about lack of training in the technology, technical glitches, and insufficient internet literacy, confidentiality and ethical issues, questionable feasibility of psychotherapy outside of a shared physical space, the effect on the therapeutic processes of poor communication and lack of presence, and most of all, the interruption of the therapeutic relationship. So, what's the beef about therapeutic relationship? Therapeutic relationship is the working association based on a collaboration whose goal is to help the patient overcome difficulties. In this collaboration, the therapist and the patient set the patient's goal, agree on tasks to achieve this within an effective bond that is strengthened by trust and commitment. So again, what's the beef about therapeutic relationship? Therapeutic relationship is the main predictor variable of outcome. Good therapeutic relationship, good outcome. It is the mechanism of change in psychotherapy. Ask the question, what does the therapist use to effect change in psychotherapy? The answer is the therapeutic relationship. It is the core element in psychotherapy, without which a psychotherapy session is any doctor's consult. The facilitation of a strong therapeutic relationship is the job of the therapist. But aside from them, other factors come into play. Primarily, the therapist strengthens the therapeutic relationship when he contributes warmth, sincerity, flexibility, confidence, openness, tolerance, integrity, and concern. When the therapist dons a professional attire, grooms himself, and conducts himself in the proper demeanor, and when he shows competence through empathy, knowledge, and methodological expertise. The patient contributes emotional intelligence, mental status, ability to trust, maintenance of boundaries, motivation for treatment, and prior therapy. Of course, he has to be motivated for change, must give honest participation, accept the therapeutic rationale and process, and respect for the therapist with hopeful expectation. Thirdly, the therapeutic setting contributes to the strength of the therapeutic relationship. This includes sound control, light, furnishings, chairs, decor, and room geography. This part of the theory, putting so much emphasis on therapeutic setting, talking about sound control, light, furnishing, chairs, decor, room, how the therapist and the patient should be seated. This sounds so mundane in a discussion where we're talking about empathy, warmth, honesty, commitment. But in the tradition of psychiatry, the physical setting helps set the boundaries of the professional relationship aspect of the therapeutic relationship. We will get a clearer picture of how this works in the forthcoming discussion. In social interactions, the physical presence of student A and of student B mutually and implicitly shape each other's behavior, and the shared meaning they derive from a lived experience of a few moments. At the edge of a long table that they share with other students, animatedly talking over them during an FGD, let's say, they carve out physical space, eke out several moments, and in this time and space, they move closer to each other and shut themselves from the world. In the course of a low volume, hushed conversation, they both giggle quietly, both cover their mouths, allow their elbows to touch, orient their bodies to each other, and mutually gaze laterally. These gestures, expressions, utterances, bodily posture, interpersonal distance and rhythms, and micro movements allow both of them to get in sync with each other. In a manner of speaking, their nonverbals allow them to attune to each other in affective and bodily resonance, and both get it. They like each other. Their lived experience of the moment, sharing thought, feelings, and bodily behaviors, set the basis for the intersubjectivity and social cognition that they have something going. Psychotherapy contrives that situation. In the psychiatrist's office, at a mutually preset date and time, they sit opposite each other at some comfortable distance. This time and space is decidedly for the patient's concerns, and the psychiatrist is decidedly the helper whose goal is to help facilitate the patient's symptom reduction, personal system organization, and quality of life promotion. Through facilitative behavior, the doctor conveys unconditional positive regard, support, and understanding. Through the patient's gestures, expressions, posture, and utterances, they sense the connection. Their nonverbals allow them to attune to each other in affective and bodily resonance, and they both get it. They can trust each other and are committed to helping the patient attain the goal. Their lived experience of the session, where thought, feelings, and bodily behaviors all count, set the basis for the intersubjectivity and social cognition needed in the therapeutic relationship. It is in this sense that psychotherapy is widely held as an embodied encounter. It represents a multi-leveled interaction between two persons who jointly participate in sense-making of their lived presence. In this interaction, as in social interactions, the physical presence of each party implicitly shapes the behavior of the other. In psychotherapy, the physical presence of the therapist and patient in a physical shared space amplifies the mutual attunement that sets the basis for the process of participatory sense making. This process is defined as the ways people make sense together of each other, the world, and themselves in moving together. For this, they rely on both implicit and explicit processes at many levels, from regulation of interpersonal distance and mutual orientation to joint activities and conversations. Studies have shown that physiological correlates in autonomic responses, such as heart rate variability, skin conductances, and interbrain synchrony, as well coordinated movement and utterances. These multiple kinds of body resonance and other forms of intercorporeality, big word, meaning the relationship of one body to another. So let's repeat that. These multiple kinds of body resonance and other forms of intercorporeality serve as the primary way that the therapist and the patient perceive each other and together generate meanings in the act interaction. The idea of participatory sense-making suggests that not only the presence, but also the particular time course of such intercorporeal synergies contribute to the building of the therapeutic relationship and processes of change. In any encounter, the parties bear individual meanings. When they interact, they generate new meanings which the couple shares. The individual processes are autonomous from each of the parties. The interactive processes are likewise autonomous from the individual processes. So in an encounter of two parties, each party has an individual autonomy or an individual domain. The orange and the blue are autonomous from each other. But in the course of their interaction, they form an interactive domain. And this interactive domain is autonomous from the individual domains. This has been studied and imputed to contribute to the building of the therapeutic relationship. In sense-making process, the individual and relational engage in a push and pull. So the individual autonomy pushes and pulls with the interactional autonomy. Thus, in therapy, as in other social situations, such as storytelling, dance, music, we see that meaning is at turns co-constructed and negotiated. It is a dialectical articulation, push, pull. In psychotherapy, the therapist and the patient each have their own individual autonomies. Simultaneously, in the course of therapy, where they share physical space in each other's presence and fully interact, their interactive autonomy strengthens. This interactive domain is built on the customary seating arrangements, rituals at the beginning, such as when the therapist goes to the waiting room to call in the patient, such as when the therapist points to points to a chair in the office and notes where the therapist will sit, where the patient will sit, how the patient will orient their chair towards the therapist, and the end of sessions, whether a patient will leave resolutely or hesitatingly, or will linger and try to get more attention or more conversation with the therapist. Utterances that signal assent or dissent during the course of therapy as the context for the therapeutic work. This shared physical presence, intercorporeality, impacts the development of the therapeutic relationship. Conditions in video therapy interfere with the push and pull of the therapeutic relationship. The participants are in their individual spaces where they conduct their private personal lives. In fact, they're at home. The two do not share a physical space. They can only partially see each other. But appear too close to each other, yet not looking at each other. In video therapy, the therapist and the patient each has their own individual autonomies as well as the interactive autonomy. In the course of online therapy, since they don't share physical space and are in fact physically distant from each other, they do not fully interact. The customary seating arrangements, rituals at the beginning and end of sessions, utterances that signal assent or dissent that develop during the course of therapy are lost or at best diminished. Thus, their individual domains become stronger and their interactive domains weaken. And since the individual domains become stronger and since the interactive domain is the sustaining force, the therapeutic relationship slackens. The absence of the shared physical presence and intercorporeal engagements negatively impacts the development of the therapeutic relationship. What does the evidence say? Since the 90s, a body of research work has shown that therapeutic relationship is good in both in-person and online therapy. Video therapy and in-person psychotherapy can be similarly effective. Therapeutic relationship is directly related to results. Good therapeutic relationship, good outcome. In-person psychotherapy results in therapeutic relationship and effectiveness were significantly better. Okay? But questions remain. So, in addition to other evidence, patients rate the therapeutic relationship higher than therapists do, and the lack of face-to-face communication encouraged development of a sense of security in some patients, but not in others. But questions remain. How does video therapy impact the development of therapeutic relationship? Research shows that two main categories, technical interruptions and hampered nonverbal behaviors. Technical interruptions are possibly the possibility of having feedback from their own cameras. Looking at your image while you are talking to another person. Certain patients and therapists who may be narcissistic or socially anxious either pay too much attention to their image or are disrupted when they see their image. And this may be disruptive or disconnecting in the therapeutic relationship. An unstable connection, which I know all of us have experienced. Just when you've been able to get the patient to talk, to feel relaxed and then talk, the connection drops. Frozen screen and delayed audio. It's very hard to read nonverbals the patient is laughing already, but you haven't heard the joke or what funny remark it was he or she was referring to. Of course, hampered nonverbal bodily behaviors. So there is no direct or eye contact. A tone of voice, the ability to have an open posture is not quite available to the participants. Body movements, a stooped posture, a shaking leg, or a clenched fist cannot be seen. They're out of the range of the screen. The synchrony, whether in actual therapy, you watch out whether your patient mirrors your posture or your movements. We see this as a mirroring phenomenon, signifying acceptance or assent, or liking, a positive feeling towards the two persons interacting. Paralinguistic, nonverbal, and prosodic aspects of communication. In effect, intercorporeal cues are altered. Body language is altered. Even normal movements are minimized. But sometimes unusual gestures. You're talking to a patient, then the patient can say like this, can go like this, maybe talking to a person outside of the screen who is in the room with him or her. And that can be confusing. So, how do the patients experience video therapy? Most patients give positive responses. They say they're gratified, they feel at a safe distance, less scrutinized, and less self-conscious. They feel less inhibited and open. They have a greater sense of control, and therefore they are more invested, more tolerant of disruptions, and claim better therapeutic relationships with tech-savvy therapists, and therefore attend more. On the other hand, not as many give negative responses. The patients complain of lack of body language and presence. So, we have positive contributions to the therapeutic relationship as far as the patient's attitudes towards the session, but we also have negative contributions to the therapeutic relationship. We have inconsistent results. What's more, video therapy is considered efficient in creating good therapeutic relationship as well as effective in reducing symptoms. But forming the connection with the therapist is literally and figuratively difficult. Several themes have so far emerged from qualitative analysis on patients as well as therapists' perspective. Generally, the participants felt that the video therapy was both helpful and hindering. It was more convenient. The participants generally expressed that the most conspicuous advantage of the remote setting was that the therapy became more accessible and flexible, both in terms of travel time and booking of sessions. and practical without all the rituals surrounding the therapy sessions, such as taking the day off and traveling. At the same time, therapy lost some value when the intermediate space and time between everyday life and the therapeutic room was lost. Video therapy was less valued and was perceived as routine and something to check off a list. The sessions felt like any other remote meeting and lost the quality of being something special. Online communication, specifically the need of equipment and technical difficulties, and disrupted connection, obstructed the therapeutic work and made the therapy less available. This contributed to an impaired sense of rapport. Generally, the participants reported impaired bond with the therapist. Oh, okay. So this is the connection. So let's do this again. Generally, the participants felt that the video therapy was both helpful and hindering. It was more convenient and practical with all the rituals surrounding the therapy sessions. At the same time, therapy lost some value because the space and time between everyday life and the therapeutic room was absent. Therefore, video therapy was less valued and was perceived as routine. Online communication, specifically the need of equipment and technical difficulties and disrupted connection, obstructed the therapeutic work and made the therapy less available. This contributed to an impaired sense of rapport. Generally, the participants reported impaired bond with the therapist. They felt that something was lost in the relationship and that it was harder to communicate when they could not see or take in the whole person they were speaking with. It felt harder to reach each other and to meet one another in the dialogue. And the feeling of sharing the therapeutic work with their therapist faded. This disturbed the therapeutic work. The technological difficulties seemed to be out of the therapist's control, possibly making the therapist lose their therapeutic stance. The therapeutic stance of the therapist is that of a helper, that of an expert, the one who facilitates, the one who knows what's happening. But because technological difficulties are out of his or her control, his stature seems to be diminished in the eyes of the patient. Glitches and disconnections made the patients feel less in focus, and ordinary accessibility of online communication blurred therapeutic boundaries and methods. You turn on Zoom for your therapy session. You also turn it on for your family reunion. You turn it on for your daily chit chats with your barkada. So it was somehow mixed with everyday events. And this blurred the professional boundaries around the therapeutic relationship. On the other hand, being less in focus could create a feeling of being freer. The therapy became less demanding and the participant felt less self-conscious. The diminished asymmetry in the relationship could be liberating as it created more relaxed atmosphere. that diminished asymmetry is also coming from the disinhibition of the therapist. What seems to be this inhibition of the therapist? Patients noted that the therapist was more talkative, would actually be more self-disclosing than in-person psychotherapy. This seemed to be a manifestation that the therapist was acting more like a friend than a therapist. And that is what we're referring to when we say the diminished asymmetry. There seems to have been some created horizontality. So they're interacting more like friends. They seem to be interacting more like friends than as a professional and someone seeking help. So they did not experience the same pressure to deliver and claim their right to be there. The relationship with the therapist became more relaxed and the conversational climate more forgiving. Another aspect that contributed to the experience of less demands was the loss of therapeutic rituals. Again, the therapeutic rituals I refer to are maybe taking the day off, of course, traveling to and from the office, waiting in the doctor's office, maybe agreeing to, telling yourself you're going to treat yourself to nice merienda after that session. Those are the therapeutic rituals. Since it could be squeezed into everyday schedules while they were at home, it didn't need much effort to attend or even put them in the reflective mode that the therapist's clinic put them. Patients say that in the time that they travel from their home or their office to the therapist's clinic, they are able to reflect. And they usually say, I prepared for this. I thought about what you said the other time. And so I've listed down or I've noted in my memory several things that I want to discuss with you. But this does not happen in video therapy. However, frame alterations implied that the therapy felt less valuable and there was less space for emotional presence and for reflections. Generally, the participants experienced that it was more difficult to access the emotional content and to share one's experiences with the therapist. They felt less vulnerable and could more easily distract themselves. This resulted in less emotional content in the therapy, and it took more effort to reach one's own susceptibilities. Just think about it. The patient is at home, maybe at a distance from family members. And if, for example, the family members are the cause of his or her distress, then the patient will not be that open. Or if people go in and out of the room, even if they are out of the room, but they go in and out of the room, out of the screen's range, the patient will still react to them and will still hesitate to talk about his or her vulnerabilities. Online sessions became more intellectual, and it was easier for the participants to avoid emotionally challenging topics. Being less emotionally available and open also made the therapeutic work more difficult and changed the patient-therapist dynamics. At the same time, the changed dynamics further reduced the emotional availability as a result of the impaired sense of rapport. Video therapy made the therapeutic relationship rather feeble, and it was harder to be close to each other. At times, the therapist was perceived as dehumanized and unreal. The moments of here and now meeting were compromised, and this could also change the relationship in general. It was also more difficult to reach consensus regarding the therapeutic work, which could arouse an uncertainty about the goals and means of therapy. The video therapy was experienced as more indistinct and lacking an explicit agreement about how the therapy was supposed to be carried through. In-person psychotherapy, or in the way we're really supposed to do it, we take time, usually at the start, to induce the patient into the therapy. So we give an orientation, and then from the how this is going to be, how many sessions probably, what how they can say they are improving, what they can do about questions. Then the patient and the therapist agree explicitly on a goal and then on tasks that they will undertake. This was not observed in video therapy. When I think about it, even from these are from journal articles, but even from my own experience, especially at the start of the lockdown, when I was doing video therapy, I really didn't know how long these video therapy sessions were going to last. If I was going to do them for 2 weeks, like we didn't know how the lockdown is going to, how long it was going to last. So we didn't know how long we were going to be doing this. So we couldn't say we're going to be doing this for 2 weeks, and then we couldn't say that. And our goals and our tasks will be like this. So that is a valid comment from the patients. Blurred therapeutic boundaries and methods made the work less therapeutic, which also reduced the feeling that the therapy was something important, ongoing, in a sheltered time and space. The sessions were more like speaking with a friend, according to the patients, and the asymmetry constituting the therapeutic relationship was reduced. The conversations were more like socializing, and the therapist became more self-disclosing. Such more friendly conversations could be experienced as less demanding and give a feeling of not having to do the work of therapy. The therapists became less exploring and less confronting, more absent-minded, and involved in something else, such as cleaning the desk or other home activities. Halata ng mga pasyente. It made the therapy less valuable. The overarching theme of the feedback from the patients and therapists was that the therapy became essentially different. Generally, the participants experienced video therapy as different from in-person psychotherapy. The same therapeutic interventions generated completely different feelings when performed at a distance. According to one participant, I do not get the same feeling when the feedback is given via Zoom. Even though I know it is well meant, it doesn't feel as good somehow, even if the verbal content is still exactly the same. This refers to the mediated distance between the therapist and the patient on the screen. If you observe in a two-way conversation on Zoom, we have our faces in focus and we're literally in each other's face. We're closer to each other than we would be in person. Therefore, even if you say neutral things like, oh, it seems like you seem tired, or you look tired, or you seem to be in a hurry, it can sound more confrontational than you intend to. And some patients react to this. Another participant said that the experience was difficult to define. It was not necessarily inferior or superior to in-person psychotherapy. It is something, another tone or another input, and perhaps mostly different dynamics. How about the therapists? The therapists seem more concerned about the efficiency of video therapy in building a strong therapeutic relationship, and consequently its effectiveness. So they say there is no difference in the therapeutic relationship between in online and in person. They complain about the lack of information, especially visual data, which hampers the development of trust in the process. Therefore, they have difficulty in projecting warmth and understanding when they can't tell where the patient is. So they cannot be responsive. They are concerned about the establishment of a relationship with their patients. They say that video therapy sessions are not as effective, and they are apprehensive about difficulties in managing patients with personality disorders and those with suicidality. Imagine if you had an interaction on Zoom with a suicidal patient, and the patient gets agitated. The consequences of that agitation would be out of the therapist's control. So they're hesitant, they're apprehensive about this. Therapists' concern about the factors that hinder therapeutic relationship may be categorized into communication, embodied interaction, space, and time. Communication is hindered by the loss of interactive flow and spontaneity, the signal latency of the video, and the difficulty in the silences. The silences are a thing in psychotherapy. We have to recognize silences, and we have to interpret the silences. Sometimes they can be periods of introspection, apparent acceptance of what you're saying, taking in the patient, taking in what you're saying, or it could be resistance, the patient blocking, thought blocking at the moment, not knowing what to say, or having strong emotions coming up and therefore not wanting to talk. The therapist manages that. The therapist interprets that and then acts according to that interpretation. But in video therapy, when the patient goes silent, you don't know why. You cannot guess. Aside from what the therapist could possibly interpret, they could be reality-based reactions. Maybe the person that they're talking about in the family walked into the room, or maybe the signal dropped, or the what we're calling the latency in the video. So it's very difficult to manage in video therapy. And that again disrupts the therapeutic relationship. As far as embodied interaction, the image on the screen focuses on the face. That can be quite disconcerting for some. It may not be the distance that both parties are comfortable with. Another is the loss of awareness of the whole body posture. We only have a view of the patient from the neck up. So we lose shifting, we lose a stoop posture, we lose shifting feet, crossing legs, crossing and uncrossing legs, shaking legs. So we lose that. Confusing hand gestures and others, that I referred to that earlier. The distance seems closer, the self-image on the screen. Some cannot handle it. Some indulge in it so much. And then there is the lack of mutual visual contact because of the technology. If you as at best you can only attain oblique visual contact, because when you look at the camera, that translates in the image as you looking away from the patient. The space provides information that may or may not be helpful for the therapeutic relationship. It gives you clues as to the everyday circumstances of the patient, and you may use that. Maybe unconsciously, you may use that as the therapist. Patient takes responsibility for the intimacy and safety of the space because the patient is at home. This is again counter to what is the customary process. In person, the therapist is responsible for maintaining the intimacy and safety of the space. So the therapist is not in control of the physical arrangements and, as I said, cannot guarantee safe and intimate space. The time element. Factors, temporal issues refer to the immediacy of the online format. You click on Zoom and you are there. There is no transition, like I said. There's no travel, there's no physical travel where you can move out of your everyday existence. So it does not allow for transition between settings and makes it common. Again, therefore, making it lose its value. As of date, a motley cluster of adaptations have been reported in the literature. So this is what therapists have been doing to remediate the difficulties in establishing therapeutic relationship. They increase and make more directive verbal and non-verbal activity. So that's why probably they talk more. And also they take on some, they're more animated when they talk. Their faces show more expression. They integrate the experience of patients with their self-image. They use the screen image and they try to make an appraisal of, is it true what the patient is saying about himself or herself, and where he comes from and what he does for a living and how he loves his life in relation to what is the reality of his home environment. Okay, and now there is already that note that the apparent physical closeness can magnify the sense of confrontation. There are more reality-based transference reactions. For example, you see a patient sitting in front of an a Morsolo painting, you in your mind, whether you realize it or not, you say, oh, that my patient is an art lover and he has expensive taste, and uh, he has but he says he's depressed, so I don't think he deserves to be depressed. So you go thinking like that based on your transferences, counter transference. Okay. In the same way, your patient can have transference reactions to you based on how you present yourself in Zoom. And that is why your professional attire is very important. Okay, so we incorporate information about habitual environment. We adopt less confrontational therapeutic styles and adopt rituals for keeping spaces separate. Even for therapists, we advise they are advised to set up their workstation that is dedicated for therapy. Even if it has to be in their bedroom, it has to be set up like an office, and it must appear like so in the screen. So what are the implications of these observations? Please note that to date, they are merely observations. Evidence to be considered generalizable takes a long time to develop. So now, 2 or 3 years after the lockdown is only when uh, case case reports are being case studies are being reported. Uh, Large trials or randomized controlled trials have not been turned out yet. So these are all observations. So how do these what are the implications of these observations on policy? So there are suggestions to set up uniform guidelines for licensing and credentialing, payment and insurance, and standards of care needed to be developed to ensure safe and optimal telemental health delivery, greater investment into human and financial resources and research, and telemental health education. Research, the questions abound. So these are all the questions. Can video therapy support the implicit, nonverbal, and embodied aspects of the therapeutic relationships? Can the adaptations have an effect on the quality of the therapeutic relationship? Is physical interaction that important in building the therapeutic relationship? Maybe we've had it wrong all the time. I don't know. So that has to be studied. Can presence be cultivated and effectively communicated and felt in online therapy? Can therapeutic presence contribute to creating a more positive therapeutic alliance in a relationship in online therapy? How can training programs in therapeutic presence be integrated into the future training programs in online therapy? Does the formation of a strong therapeutic relationship precede a symptomatic change in video therapy? Does higher in-session rate, variability, facilitate the establishment of therapeutic relationship in video therapy? Does this predict symptomatic improvement? Is there a difference in the quality of the therapeutic relationship between in-person psychotherapy and video therapy? Can more disinhibition and openness foster greater disclosure among patients who have certain interpersonal patterns? Can they benefit from a less confrontational relational style? And the list of questions goes on because this area of research is just in its infancy. We are just beginning to recover from the trauma you might call of being thrown into video therapy unceremoniously. As far as training, training should be composed of training in logistics, technology equipment, mode of therapy, and therapeutic presence. Treatment, as this is as far as they will write or state in the journals. Tailor the treatment according to clinical variables such as severity, socioeconomic background or digital literacy, acceptance and attitudes towards technology, adapting the interventions to different modalities and settings, the person, the therapist, whether the therapist really can be online or not, can adapt to the conditions online, and of course, supervision and training. In summary, always the best part of the lecture. In summary, the COVID-19 lockdown posed a challenge to the mental health field to deliver online psychological treatment, to address the imbalance between global distress and anxiety and the access to therapy. By observing the therapeutic viability of video therapy, we are beginning to appreciate, or we appreciate more, the value of the therapeutic relationship. So far, we have found out that the therapeutic relationship in video therapy is good, but different. And since in this case, the specter of a dystopian world from disease outbreaks such as COVID-19 is the mother of reinvention, some innovations are being noted in the literature. The past 3 years have shown that the course of psychiatry seems to be changing, particularly psychotherapy. We don't know where this will take us, but certainly our work is cut out for us. In my study for this lecture, this exhortation to mental health professionals resonated with me. Address the imbalance, meet our duty to care for patients, acknowledge the evidence base, trust the evidence base, and more so this. Exert our leadership in the field to protect the humanity of person-to-person communication in psychotherapy. But most resonant of all is this. The danger of computers becoming like humans is not as great as the danger of humans becoming like computers. So thank you very much and enjoy the rest of your day.
Thank you, Dr. Lucindo Jimenez, for that very insightful lecture on something very timely and relatable in present times. To formally demonstrate our gratitude, we present this certificate, which reads, University of the East Ramon Magsaysay Memorial Medical Center Incorporated, Department of Psychiatry, awards this certificate of appreciation to Alma C. Lucindo Jimenez, MD, FPPA, for having rendered her valuable time as memorial lecturer during the 31st Dr. Jaime C. Zaguirre Memorial Lecture entitled The Therapeutic Relationship in Online Psychotherapy, given this 15th day of March 2023 at the University of the East Ramon Magsaysay Memorial Medical Center Incorporated. May I call on Dr. Norbert Lingling D. Uy, Dean of the College of Medicine, Dr. Hemiliano Aligi, Vice President for Academic Affairs, Dr. Debbie P. Songko, Chair of the Committee on Special Conferences, and Dr. Elham May Z. Bocalbos, Head of the Department of Psychiatry, to award the certificate. May we also call on President Esther Garcia to award the certificate. Today, we are also honored with the presence of Miss Between Zaguirre Almonte, daughter of the late Dr. Zaguirre we remember today, to share a few words on behalf of his family.
Again, good morning, everyone. Let me just share with you the response that my sister wrote, that for the first time, she would be the one to give the response. And I joined her in this message. This year, 2023, being the 31st year of memorial lectures in honor of our beloved father, Dr. Jaime C. Aguirre, by the staff of the University of the East Ramon Magsaysay Memorial Medical Center, I, Lacambini Zay Ramos, and my sister Between Zay Almonte are very grateful for your great esteem for our father, Dr. Jaime C. Aguirre. We thank the UERMMC College President, Ms. Esther Garcia, the Dean of College of Medicine, Dr. Norbert Lingling D. Uy, and the Department of Psychiatry Head, Dr. Elham May Pocalbos, and the doctors who continuously respect our father until today at UERMMC. I thank God that my father's works and ideas has been recognized and implemented by his colleagues and this present generation of medical professionals of UERMMC in the Philippines and abroad. Thank you to Dr. Alma C. Losendo Jimenez for your lecture about the therapeutic relationship on online psychotherapy. Much as digital digitalism is very, very much in fashion nowadays, but it seems that really one has to take the balance between how it can affect in the patient's therapy. In this day and age of modern technology, the availability of online psychotherapy is very valuable to everyone who needs information on this subject. A lot of doctors are already posting about other medical conditions. And according to my sister, I have yet to see some postings on the medical side. Mental conditions are so prevalent, yet so many individuals still lack knowledge about mental diseases, especially in rural areas. As I understood my father's philosophy on the individual human person, that all our actions and thinking are produced by our brain, that is why we need to be more educated in how the brain works. That is why he promulgated that psychiatry should be included in the first year program of medicine. And yes, they should be on top list of online postings because this info on mental health includes our intellectual, emotional, psychological, and social well-being. It affects how we think, feel, and act. It helps determine how we handle stress, relate to others, and make choices. Mental health is important at every stage of life, from childhood, adolescence, through adulthood. These infos might solve a lot of social problems caused by mental illness. We pray that your online ideas will be honored and applied for by these unfortunate individuals. Thank you, everyone from UERMMC, and thank you, Lord, for this great tribute that you have been bestowed to our Father. Sincerely, Lacambini Sagire Ramos, and yours truly, Between Almonte. Thank you.
Thank you, Ms. Zagiri Almonte, for your presence and participation in this celebration of the legacy Dr. Zagiri has left behind. As we reach the conclusion of this event, may we call on Dr. Esther Garcia, President of the UERMM MCI, for her closing remarks.
Good morning, everyone. Since you have been addressing, all the important persons here, I will not do that anymore to save on time. But I'd like, of course, to greet the Sagire family for being here. Thank you very much. I would also like to thank Dr. Alma M. Lucindo Jimenez for gracing us with her presence and sharing with us her valuable time to be the speaker during the 31st Dr. Jaime C. Zaguirre Memorial Lecture. This topic has brought us to understand the meaning of therapeutic relationship, and now, of course, in relation to our online communication and its role in psychotherapy. What we have learned fits well with Dr. Jaime Zaguirre's concept of the individual human person, the interplay of the soma, psyche, and spirit. And hence, I would like to congratulate Dr. Alma M. Lucindo and the Department of Psychiatry headed by Dr. Elham May C. Bucalbos for organizing another illuminating memorial lecture. I would like to brag a little bit because we are talking of online education, of online communication. In 1991, with a group of a few friends of mine, especially in the science sector, we convinced then Secretary Foliosco, to bring in internet into the country. And this was under a project, a big project I was heading, the Engineering and Science Education Program of the Department of Science and Technology, where we provided money for PhD training and also some faculty members coming from abroad, and of course facilities, including, as I mentioned already, the internet. That was in 1991. And of course, Secretary Foliosco agreed, and we got internet into the country, which later was passed on to the private sector. Okay. Come 2011, we're actually in UE, we started online education, hybrid, partly online, partly face-to-face, only at the graduate school in 2011. And in 2018, we went a step further by having a really good internationally recognized learning management system in 2017. And of course, when I came to UE RM, I also introduced that to UE RM. So that when March 12 came, I immediately ordered a shift to online education. And we were prepared. Why? Because we've been training our faculty since 2018. Of course, we did not know there would be COVID. Hindi natin alam yon. But we were prepared. And I'm really glad that we prepared for this, because although face-to-face is still much better, whether in education or psychotherapy, face-to-face is still much better than online. Sometimes we need online for disasters like COVID. Thank you and good morning.
Thank you, Dr. Garcia. We would also like to take this opportunity to thank the following people: President Garcia, Dr. Aligi, Dr. Uy, Dr. Songko, Dr. Balderrama, Dr. Castro Rodriguez, Dr. De Los Santos, Dr. Cohidalgo, Dr. Alcedo, Dr. Dimla, Dr. Fandialan, Dr. Quiñones, Dr. Valera, and the different departments of our institution, and to those present today whose participation has made this event much more meaningful. Let us all rise for the UERM hymn.
We owe to God and thee.
Once again, in the 31st Jaime C. Zaguirre Memorial Lecture. We will now have the department picture taking. Other guests are also invited to take pictures. We would also like to inform you that you may proceed to room 501 for a simple brunch. Thank you.